I'd first like to introduce Dr. Michael Leon, who received his PhD from the University of Chicago. He is a professor of neurobiology and behavior in the UCI Ayala School of Biological Sciences. His research interests include sensory enrichment therapy for autism. In 2007, he was UCI's Professor of the Year. And we have a lot of faculty on campus, so that is quite impressive. In 2011, he was also recognized as Medical Technology Acceleration with their award from the UCSD Jacobs School of Engineering. And in 2014, he received the W.G. Marquise Award from the American Psychological Association. So please come up, Dr. Leon. And both of these individuals are so acclaimed that I can't do justice reading their bios, so I want to make sure I get some things right. So I've got the paper here. So I'm going to catch my breath as I introduce Dr. Nikan Khatibi. He's a physician anesthesiologist, pain management, and addiction medicine specialist. He is the CEO and medical director for Ahura Healthcare Corporation. He also serves on the board of directors for CalOptima, which is the largest county-organized healthcare system in California. Dr. Khatibi has also been involved in healthcare policy for more than 10 years. He has also served in key policy and advisory positions. In addition to his policy work, Dr. Khatibi divides his time between clinical practice, research, and teaching. He has received several prestigious awards for his work, including being named one of Orange County Metro Magazine's top 40 under 40. In 2017, Dr. Khatibi was named a fellow at the National Association of Corporate Directors. I can go on and on about this gentleman, but one keynote I wanted to say is that he has been generous enough to open his home to new anteaters who are just joining the anteater family, who have just been admitted to UCI for several summers in a row now, and we're very fortunate that he's hosted so many new anteaters. So tonight, please give a warm welcome to Dr. Nikan Khatibi.
Thank you, Dan.
Okay, let me set my timer so that we adhere to the rules. Can you hear me? Okay, you want to try yours?
Can you hear me?
Perfect.
Fantastic.
Okay, well, welcome back.
Thank you for having me.
Our pleasure. What I'd like to know is your life history up to the point at which you went and tried to get into colleges.
Wow. That's a great question. I would say...
I can just leave now.
No, not at all. No. I think the simplest answer is I was born and raised in Texas, small town called Katy, born in Galveston, and decided that the weather was just so humid in Texas growing up as a kid, and that's what really brought me out to California. But during my time in Texas, I learned a lot. You know, my parents were immigrants from the Middle East, from Iran, and so they didn't have anything when they came over, and so I think that's really what transformed my decision to go into medicine. We used to drive 2 hours just to get to the county hospital and wait hours and hours in line just to be able to get a vaccine shot or get a healthcare provider to see us. And it was just devastating, and it really moved me. And I knew I wanted some type of higher calling, and I knew I wanted to focus my energy and passion into going into healthcare. And so, lo and behold, I heard about California, this magical place, Hollywood, the beaches, the mountains, the weather, the beautiful women. And so I said to myself, well, I didn't strike oil, but I still had saved up some money, and maybe I'll move out to California. And that's what I did. I heard about UCI in the heart of beautiful Orange County, and that's kind of what brought me to California and made me go to UCI.
So did you visit UCI before you applied?
I did, actually. I had visited one time. I had some family members out in Southern California, and that's kind of how I knew about the beautiful weather and the mountains, again, the girls. And so I was like, oh my God, this place is for me. If I can afford to go there, if I get accepted to go to school there. And lo and behold, it worked out great. I got accepted to UCI and never looked back. I really loved it during my time here.
So what did you like particularly when you were here? What did you get involved in? What were you doing here?
Great. So I knew I wanted to go into healthcare because if you've ever not had healthcare access, it's pretty devastating in the sense that If you get sick tomorrow, you don't know what to do, you're frantic, you're scared. Many people have different social determinants of health, which include transportation, food insecurities, homelessness. And so that was a big deal for me. And so I never wanted to be sick, which obviously is impossible. But I never wanted to be able not to have the opportunity to take care of myself. And so going to UCI for me was, can I become that person I want to be? Is it more the policy side to change the policy in terms of healthcare access? Is it more on the sides of actually being that one-on-one clinician? And so in UCI, I did both. UCI gave me the opportunity to volunteer at hospitals and with local physicians so I could better understand the clinical world. UCI enabled me and empowered me to get involved with many amazing research opportunities, just like the good professor does himself. I had gotten involved in a nephrology lab, which I sincerely enjoyed. And so during my time, I spent a great deal of my time obviously focusing on my academics, but honing down my passion, which was possibly clinical medicine versus actual maybe academic medicine versus policy medicine as well.
Did you work hard when you were here?
Obviously. I think I failed this guy's class, but otherwise, it was pretty, I worked my butt off just because I was passionate about it. You know, everybody has determination, I'd say. You're competing with people who are determined every day in your lives. It's not obvious, right? People who are moved, who are passionate, who want to, do great in life, are very determined. But those are the people who succeed, really. It's those people who are determined, passionate, but also curious, right? They chase their curiosity. They don't chase billions of dollars, becoming a millionaire or billionaire. They chase their curiosity and become an expert at their curiosity. And we as society look towards those individuals. Who are the experts in those fields? Whether it be in neurobiology, maybe pain management, whether it be in climate control. Who are those experts? And so that's what deciphers you from somebody else, is not being irreplaceable, just having that determination and, again, that curiosity. So I forgot the question, but I just ranted. But yeah.
That's okay.
Sorry.
All right. Years ago, I was living in Laguna Niguel.
Oh, wow.
And there was a young man who got interested in politics at that time.
Yes.
And maybe you could tell us something about that.
Wow. Yes, maybe I knocked on your door. So when I was in college, again, I was trying to figure out being an academic clinician, being a private practice position, getting involved in healthcare policy. So UCI afforded me those two aspects. How was I going to do the third? Obviously, now looking back, there's so many avenues through policy centers on campus to relationships with government affairs, through many of the alumni who might be involved in government as well. But I thought, you know what, there was an issue at the time, and that was they were closing down these beaches in Laguna Niguel, and me being a guy from Texas who never saw beaches, I was like, hey, listen, why are we shutting down these beaches? They're beautiful, man. Let's do something about it. And so I had a friend of a friend who knew at the time, you guys are probably too young, but Rick Dees on KISS FM. And met up with Rick Dees, and he gave me some advice, and I said, you know what, I'm going to run for office. Hell yeah, I'm going to do it. And so I ran for local office. We put together a team of literally like 200 UCI students. So actually UCI did help me. UCI students, and we knocked on doors, radio campaigns, and had some TV debates as well, and ran for office, local office, with that intention of not closing down those beaches. And it was a lot of fun. It afforded me a lot of knowledge and experience about impacting society. And I think that's what we all want, right? We want to leave behind a network of the inspired. I mean, why on earth are you living unless you inspire others by the time you leave one day? And so I realized, hey, listen, I liked it. I liked the policy aspect. And so, yes, I ran for office when I was in college. And so that was my policy side.
This is amazing.
I don't know about that.
It's not enough to be a bio major and to be studying organic chemistry day and night. But in his spare time, he decided to run for mayor of Laguna Niguel and almost got there. So my question now is, you may know that Daryl Issa is retiring.
Right, he is. Daryl's a good friend of mine.
Have any interest in running for his seat?
Oh, not right now.
Okay.
I'm so focused on my businesses and I do a lot of policy work, and I really get so much fulfillment from policy work, healthcare policy specifically, making sure that people have access to affordable, high-quality, patient-driven, first-class, innovative healthcare. And that's a mouthful, but it's very tough to do. It's very tough to do. And so I've spent the last year, actually, it's been so much fun, obviously running my businesses and hiring a CEO recently, but going back and forth to DC, actually. I've had a chance to sit down with many times our former Secretary of Health, actually, Tom Price. I've known Tom for a while, and that's been very interesting. My sister and I, she's also very involved with policy, got the chance to go to the White House and sit with our president, have some discussions, obviously on the opioid epidemic, and work very closely with Seema Verma. These are great things because Seema Verma runs CMS, which is the Center for Medicare and Medicaid, which is that low-income health care or seniors with disabilities and older individuals, and talk to her about streamlining health care. And going back in February to meet with David Shulkin. He's our Secretary of the VA, because you guys know what the VA is. The VA's hospital system. It's really one of the largest healthcare systems in the nation. I have about 150 locations and almost 1,000 centers throughout the country, and there's a lot of issues with the VA. So yeah, it's been a great year of policy.
So how did you get into pain management?
Good question. So anesthesiologist. Does anybody know what an anesthesiologist does, by the way? We put you to sleep, but we also wake you up. That's the most important thing. And the joke's always we pass gas all day, because really that's what we do. We pass gas to put people to sleep. But in essence, I was doing anesthesiology, and I loved it, right? It was so fascinating, dynamic. You're working in the operating room, taking care of people, the most critical moments of their lives. And then I loved it even more to do neuroanesthesiology, which is patients who have like spinal cord injuries, spinal cord tumors, and so forth. Really found that very fascinating. And then I realized, well, when I was working in the ICU as a neurocritical care anesthesiologist during my fellowship, I found like all these veterans we were taking care of, because I was at Loma Linda, by the way, that was the stipulation. Loma Linda has the adult hospital, the children's hospital, it has the Veterans Administration as well. And we spent half the year at the adult children's hospital and half the year at the Veterans Administration. And so we used to take care of all these vets, and I just remembered, my God, we're sending home all these veterans with tons of narcotics who have like PTSD and are having social isolation issues and anxiety disorders and depression. And I said, that can't be right. Something has to give. So I did another fellowship in pain management. And luckily at Loma Linda, part of that year is also in addiction medicine. And so that's what really was my drive was, hey, let me try it out, see if I like it. I'll stick with it. If I don't, I won't do it. Again, curiosity. Same for medicine. Always curiosity. And I loved it. I realized that the way we're treating pain management and addiction medicine was completely wrong. We had it backwards. Our answer was narcotics. Now, if you really want to hear the whole story, the whole issue started in the early 90s, right? Everybody knew that opioids were only supposed to be used for cancer-related pain. Well, just like with anything else, a good lobbying organization comes around and says, you know what? Opioids should be used for more than just cancer pain. It should be used for all types of pain. And so this pharmaceutical company did a great job lobbying. This, again, you can't get away from politics, you guys. It's policy. So they convinced Capitol Hill to tie reimbursement rates for hospitals and doctors to a patient's pain score. So let's say this lovely lady right here decides to break her foot and goes to the hospital. When I was a medical student, I would make rounds on these patients, and my boss would tell me, if you're not taking care of this patient's pain, and he scores you, 0 being no pain, 10 being the worst pain in your life, higher than 5, our reimbursement gets cut, I get mad, I get mad at you. And so we went around as students and interns giving out narcotics like crazy, so those scores could be less than 5, so that hopefully then what happens? The doctors are happy, the hospital's happy, they get their reimbursements, all is well. Well, now the pendulum swings the other way. Everybody has tons of opioids in their bodies now. And we all naturally, as the good neurobiologist would tell you, naturally have and make endorphins or opiums in our body. So what do? We take external opium, and what happens is now our internal factory starts shutting down. Now we're dependent on these medications. And now the government comes out and says we have an opioid epidemic, and now we've got to solve the problem. And so for me, pain management has been a career of fulfillment. Being able to provide comprehensive pain and addiction medicine services, knowing the epidemic is going on, and trying to transform it in a way that I feel and I believe and passionate about is the proper way to practice medicine.
So what are your 3 big pains that come to you,
Okay.
and how do you treat them?
So I would say the first one obviously is basically headache pain. So basic migraines, headaches, you can try dietary supplements, you can try acupuncture, you can try nutraceuticals. We're a big believer that food is your medicine, avoiding the inflammatory foods. There are medications out there, non-opioid medications. There's class 1, class 2, class 3 medications. My favorite's always doing the Botox, obviously. The women love it especially, so we do Botox obviously for migraine disorders as well. Second one is probably just your traditional back pain, right? It's probably the #1 cause outside of stroke of work-related disability. So treating these individuals comprehensively with a combination of behavioral therapy, making sure there's no underlying PTSD, depression that might be contributing to this. Obviously making sure that their medications are adequately optimized with nerve medications, muscle relaxers, anti-inflammatories, topical creams and patches. We try a little physical therapy, aquatherapy, big believer in yoga. Anybody do yoga here? I don't, but I'm a big believer in it. It's a great one. It's too hard. But yeah, yoga's a great one as well. We do interventions, and obviously there's surgical options as well. Great question.
So last Sunday I came home and I tried to get the last quarter of the football game that was on, and I was trying to find it on the TV. And the first 3 things I saw was stem cell therapy, and a long ad for that. And then another one was for yoga therapy, and then another one was for sort of a constant movement therapy. And all these were going to get rid of all the pains that people have. And I was wondering, is January the time when people go, I've just got to do something about this pain? And
it's a great marketing tool, I would say, right? I don't think there's really any 100% cure for your pain, regretfully. Some cases there are, don't get me wrong. But I think I look at pain, maybe the same way you look at pain, is I think it's just it's a check engine light. Something's going on in the body, guys. You shouldn't mask it with a bunch of opium, right? You should try to figure out the root cause of it and try to manage it as well as you can. So obviously, if you're overweight, focus on diet and exercise. If you are dealing with migraines from stress, you're studying 24 hours a day, 7 days a week, you're not socializing with anybody, oh my God, get rid of your stress. Go for yoga, acupuncture, walks, breathing exercises, lavender, whatever it is that makes you happy. If it's I'm dealing with coming back from the war in Iraq, and I can't leave my home, I'm devastated. Obviously, get some help, get some engagements, conversations, discussions. That was one of the biggest struggles I had as a physician, was dealing with my veteran populations. They said, hey, Khatibi, you've never been in Iraq, you've never been in Afghanistan. How the heck do you know what's going on? It was tough. I had no idea what to do, and I tried my best, right? And then I said, you know what, screw it. So I joined the reservists. This is 1 weekend a month, even though I've never been deployed, but at least to give some degree of, hey, listen, relatability. Okay, maybe you have an understanding of what's going on. Has it helped me become a better clinician? I think so. Has it helped my patients? I do genuinely and sincerely believe so. Because again, as a clinician, as a physician, it's a career of sacrifice. You put them first, you put no birthday parties, family events behind. You were there to serve these wonderful members of our community who are just entrusting you with the confidence and ability to help them. And so that's a trust you shouldn't take for granted. And so I always lose my train of thought. I'm so sorry.
Well,
I rant a lot. Obviously, you could tell.
thank you for your service.
No, of course. Thank you.
What are the 3 top things that the people coming back from these war zones have that are problems?
PTSD, #1. Just, golly, they just saw so much there. Tons of gunshot wounds, right? Or excuse me, gunshot, what do you call it? Sounds. So in the middle of the night, they're having these nightmares. Not being able to sleep well because, right, they're worried about, being hypervigilant at all times, at all moments. Just imagine being on 24/7 a day, not knowing if something was going to happen, you were going to be attacked, you were going to be shot. And so now going back into public life, it's so hard to transition. That's 1. And then 2, I would just say, is just, again, that social isolation. Just not ready to engage back in community. It's challenging. We have a problem with loneliness in this country. There are so many people who are lonely. And I think in part because of social media. It's been great connecting one another. Don't get me wrong. My God, I'm going to Google you guys and Facebook you guys in a moment. But it really is challenging because we make up Facebook as our actual physical interaction or physical contact. And that's horrible. And I'm sure that, again, the great neurobiologists can tell you as well, it's probably not healthy for you long term. And so coming back, this is the biggest issue for them.
So just taking your iPhone and putting it on the table decreases empathy around everyone around the table, right? Because people know that you're not as important as whatever comes through your phone. And so it is eaten away at the fabric of our society in many ways.
Don't sit at this table. Their phones are off.
But you
my
must
God.
be interesting. you must be interesting if nobody is looking at their phone. So so far so good.
Oh, good. That's a good thing.
Okay. And so a lot of people who have been to other pain management places or their GP come to you and they're taking 10, 20, 30 OxyContin a day. Mm-hmm. How do you deal with that?
It's challenging. It's a headache. It's a nightmare, but I love it. It's very rewarding. It's very fulfilling. I think the first challenge is building trust. It's fear. Just imagine taking a medication that allows you to survive every single day. Their opium factory is shut down in their bodies. If they don't take this medication, they'll get the shakes, they'll have horrible diarrhea, nausea, vomiting, abdominal cramps. They'll be angry. They'll be enraged. It's the worst feeling in their lives. They'll feel like they're going to die. Their heart's pounding out of their chest. And so you have to convince them that it's smart for them to cut their opium so long-term they'll do better. And so it really, day in and day out, is a discussion of negotiation. I feel like as our president would say, it's the art of the deal. It really is a negotiation every single day because the options are also limited as well. So one, it's about coming together with a plan about weaning down their medications, trying these crazy ideas of yoga and acupuncture, which nobody's ever talked to them about. And then 3, obviously, convincing them to do so and following up and hope to God they don't die or they're like, screw you, I'll go to the streets. So my office is actually catered towards the lower income populations. I felt like, hey, listen, the best way I could break that cycle of poverty, cycle of addiction, was to partner up with those vulnerable members of our communities, and that's what we've done. And it's worked out great. We've also partnered with local colleges to help them with job trainings. We partner with local foundations like the Illumination Foundation, right, for temporary housing and shelter. How on earth can I expect this young woman here to break her addiction of heroin and cocaine when she's in the riverbeds every day, snorting coke and injecting up heroin? It's crazy. One's an upper, one's a downer. She probably wouldn't do that, but just doing those, that's crazy. And so getting into that housing, letting them know that they have some degree of stability. We take for granted our stability and our security, guys. How many people go every day with the food insecurity, right? They don't have food in their mouth. How many people go without a roof over their head? I think Orange County is 5,000 people in Orange County per night are homeless? It's crazy. And so taking care of that security first, then following up with that trust and building that and helping them get their sobriety or they're getting rid of that opium. I mean, we have alcohol. It's crazy. I had 2 beautiful, young, intelligent, smart college students today. Mom came with me and, golly, they've been drinking that whiskey a little too much, and it all started in high school, college. Their brother died from it. Their father died from it. You think that'd be a ding, 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 don't start drinking. But there's sometimes that genetic tendency where you just want to drink. And just like me and you, we can put that glass down. Some people just can't. Just imagine. And now they've hit rock bottom, right? It's tough. One lost a limb now. It's unbelievable. They were playing around with a riding lawnmower. I wish I could show pictures. You'd be grossed out. But riding a lawnmower when they were drunk at night, having fun. She jumps off the lawnmower, riding lawnmower, and the other sister didn't see it, runs over her foot. Horrible. It's amputated. Imagine this beautiful 21-year-old girl who should be like on the cover of Maxim magazine, probably on her way to becoming the next America's top model or something like that, is now one-legged. It's horrible, and it's challenging.
So there are 2 schools of thought for treatment of addictions. One is buck up and fly right. You shouldn't be taking any drugs, and the way to deal with it is to go cold turkey and You know, you can apologize to your friends and do all sorts of things, but no drugs. We're not going to substitute this drug for that drug. Then there's the other school of thought, which is there are these drugs that help people get off of the drugs that they're on, and the data says that this is much more effective in the long run. Where do you fall and why?
Great question. I follow on the era of replacing one quote unquote for another temporarily. It's called the Medication Assisted Treatment Program, MAT. And there's two medications that have been shown to reduce the number of, obviously, opioid-related deaths in this country, secondary to opium prescriptions, prescription drug overdoses, or street drugs. And so I tend to, let's say as someone who comes in is on tons of narcotics, impossible to get them off, I err on the caution of using like a Suboxone or a methadone therapy to be able to get them to a stable level and then slowly wean them off. Now there are some in DC who believe you're trading one poison for another. I try my best to follow data, and the data shows, yes, it might be one poison for another, but again, we're seeing a reduction in opioid-related deaths secondary to, obviously, these types of medications. So I try to work with them on that while I get them to incorporate these other modalities into their lifestyle.
So one of the issues with drugs like Suboxone is that the government has decided that doctors should not be able to write too many prescriptions for this drug, but they can write as many prescriptions as they want for OxyContin, the dangerous drug.
I love him. He's absolutely right. So what's Suboxone, guy? Anybody know what Suboxone is? That sounds like a foreign language. Yeah, so just imagine this. I give Jeff a piece of candy. Everybody know Jeff, right? You just spoke right now. If you don't, then you weren't paying attention. Jeff, I give him a piece of candy. What is he going to do? He's going to say, or what are you guys going to do? You're going to see Jeff got a great piece of darn candy. So what other people are going to come and say, Jeff, can I have some candy? Can I have some candy? And soon they're going to come asking me for candy. Now you have all these people asking for candy. Just imagine your body's the same way. You give a little opium, a little Norco or Vicodins to the body. What happens? Now it wants more. It wants more. It starts building up tolerance over time. So you got to constantly feed it with more candy. And so what Suboxone does is like giving Jeff one piece of candy and putting pacifiers in everybody else's mouth in this room. So that way you're not crying, you're not screaming and kicking. Eventually you'll go to sleep and your body's tolerance level will hopefully reset. And so that's what Suboxone is. And I love to use it for my patients. It works out a majority of the time great for the right candidates, obviously. But you're right. He's a genius. The government has put stipulations on who can prescribe Suboxone, but requiring you to get a certificate to write Suboxone. And when you're already a busy clinician, right, there's only maybe 750,000 physicians in the entire nation for a population of what, 400 million, I think? That's crazy. Huge shortage. And we're in a surplus relatively in Orange County, but it's a huge shortage, right? And so how do you expect someone who's already seen 20, 30, 40 patients a day to go spend the extra time to get that certificate, to be able to write that medication for a patient who's going to yell and scream and do everything they can to tell you, are you crazy? You want to take me off my medications? It's hell. I wouldn't do it, but I did it. And I love it. I think it's very rewarding because I'm that comprehensive physician, but it's challenging. So the government has some problems too.
So do they still limit you to the number of patients you can treat?
With Suboxone?
With
yes.
Suboxone.
Your first year, yes, they can.
So why do they do that?
That's a great question. I don't know. I'm going to play ignorance. I have no idea. When's the last time you met a politician? Not to say anything bad about him, but...
Okay. So here's a drug that actually helps to get people off opioids, and he can only treat a limited number of people, and then only if he's received the special training and certificate, which means that very few doctors can give this. Now the next problem is, let's say you have the certificate, you're only up to your 35th patient, and then you give the Suboxone or other similar drug to people, and then what happens is that the person tries to get compensated by his insurance company, and the insurance company says,
no reimbursement. You don't get compensated for that. A lot of times these insurance companies don't even cover it. My gosh, it's crazy.
And how much are these life-saving drugs cost?
Astronomically high, just like with anything else, naloxone or... why is that? Because again, the pharmaceutical industry is very strong and very passionate. The same ones who created the opioid epidemic are preventing it from happening. There's another great medication called naltrexone, right? It helps curb your cravings. It's a once-a-month shot. You just come in, it helps curb your cravings for alcohol and opiates and so forth like that. It's a $2,000 shot. It's crazy. But at least who gets it covered? You know, if you've been convicted of a crime, that's covered for you if you're on Medi-Cal. But otherwise, it's very tough to get covered. It's challenging. So.
Does that encourage people to engage in crime?
I guess so. That's a great question. Oh my God, maybe.
Right.
Yeah, it's
Okay.
crazy.
So once these people are off the drugs, they very often relapse and go back on the drugs.
Many times.
How do you deal with that? I mean, do you have an ongoing program where they can get the kind of support they need over years and years, I imagine?
We're not, my company is not at that point because it's obviously, it takes a mountain, or it takes a team to really move that mountain. So there are avenues, obviously. Obviously, family support and engagement is very instrumental. Support classes are very instrumental. Narcotics Anonymous, AA, behavioral therapy, counseling. You've got to go it. So that's very instrumental, guys. Does anybody know anybody who's had an addiction of any sort? Alcohol, opium? Wow, you serious?
Wow.
That's a lot.
Yeah.
That's crazy, yeah.
How many of you have coffee every day?
Oh,
Okay. You're addicted to a different
No.
drug. Okay.
there you go.
All right, so we know that Purdue Pharmaceuticals, which was the drug company that convinced the doctors that, you know, they have a new drug that's an opioid, but it's not addictive, and so you should give it widely. Now, this is no secret, right? It's
Right.
very addictive. If you get a 10-day supply of oxycodone, you will still be taking it a year after, right? So 20% of the people are like that. Other people don't get hooked on it. But it's highly addictive. This is no secret, but it's still going on. So the doctors are still saying, oh, you've got a pain in your arm here.
Right.
Have 10 days worth of OxyContin or any of the other long-acting drugs. Why hasn't the behavior of the doctors changed?
I wouldn't say necessarily it hasn't changed completely. I do see we're seeing changes, right? We're seeing a reduction in the number of OxyContin prescriptions in the United States. We're seeing a reduction in terms of the number of opioids being prescribed by physicians. So it's starting to come down. It's not where we want it to be. And so it's going to take, obviously, old school mentality in terms of understanding that, hey, listen, the way you've been prescribing for the 30 years you've been practicing is horrible, and you need to change the way you practice. That's one. But two, we can't just obviously work on doctors. It has to be a multi-tier effect. We have to work with insurance companies who approve these medications and have them restrict how many medications you can prescribe. Three, we got to work with our state and federal organizations to put into place prescription drug monitoring programs to be able to understand, hey, listen, who's doctor shopping, who's not doctor shopping. But four, we also have to have enough providers to be able to address the matter of addiction and opium and so forth and be able to get help for these individuals and take away some of these barriers, like you said about Suboxone therapy. I think it's multi-tiered, and I think until we might appreciate that, but those conversations haven't had together, I don't think we'll see too much change. We'll see a reduction, but it'll die away when the next big issue comes around, which I think is going to be heroin. It's going to be fentanyl, right? You can order fentanyl from China, right? You just call up a pharmacy or go online. You can order some fentanyl delivered to your house, and do whatever you want with it. That's one. Heroin, right? It's getting tougher to get prescription drugs now, so we're seeing a huge insurgence of heroin. It's crazy. It's unbelievable.
Right, and a lot of the heroin is laced with fentanyl to give it
Yeah.
an extra boost. And fentanyl, in case you're thinking of taking it, has a very narrow range of effectiveness. And as soon as you go over that range just a bit, you overdose and die. And so it's a very dangerous drug to be had, as Tom Petty can tell you. And you know, did you see all the drugs that were in Tom Petty?
No,
when he
I
died?
missed it.
6, 8 opioids, different kinds of opioids. Amazing. So here was a guy who had built up a tolerance to one opioid after another, and they just kept adding it, one on top of another.
Unbelievable.
And my guess is that the latest boost in fentanyl probably put him over the edge.
Can't wait to find out how he got it too. Was it from a?
Yeah.
I don't
right.
know. That'll be interesting.
Do the people here know how dangerous the opioids are and how likely you are to get hooked on these things once you take them? Even if your good dentist gives them to you or your good GP, or right? they're very dangerous. And I think, so in addition to educating the doctors and sort of making the pharmacy companies be realistic, I think there needs to be a general understanding or education on the populace about, even if your doctor gives them to you, you take them sparingly, you don't have to take all 10 days of it, or not take them at all, right? Because once you come off it, you'll either keep wanting it very often or the pain will be worse, right? And you'll have to go to his clinic.
It's horrible.
Right?
No, but I think 1 out of 8 of you guys is probably going to experiment some type of prescription drug. So just be careful. And what do they say? College students now, a good chunk of them, actually feel like it's okay to take prescription drugs to help them study better, to focus better, things like, that's crazy. I know there's a lot of stress, but it's not worth it. It really is not worth it. It affects your neuroplasticity, and it's horrible.
Yeah.
So
getting back to the shortage of doctors that you mentioned, one of the things that we have in California is that the University of California is limited by law about the number of medical students that each campus can take. And they can't take any more of them. So we've limited the number of doctors by law at a time when the population is expanding, the population is aging, it's when they have the most medical needs, and the need for doctors is more and more extreme. So
who's going to pay for it? And that's the big question. So just because you go to medical school doesn't mean you're going to be a doctor, right? You still got to do your training, your internship and residency. And those are paid for by CMS, right? Center for Medicare and Medicaid Services. And so with costs going through the roof, as a politician, I guess it's tough. Take away money from seniors and give them to some wealthy doctors to get training doesn't sound right. And so that's where you're seeing now states pick up the slack, where they're either working with pharmaceutical companies to try to subsidize some of those costs to open up more residency spots or training spots. Number 2, the states are trying to allocate funds separately to open up residency spots. 3, hospitals are going to take that hit and hire more residency spots, which obviously indirectly they get the money from the government, which is crazy. So that's the big question: is who's going to pay for these spots? Or 4, you go through medical school with a $250,000 debt and then work for free for 5 years as you get trained. That's another option too. And it's tough. It's crazy. So it always comes down to money, in part because we live in a society that wants to have choice and wants to have the best and most costly health care in the world. And a majority of it's probably spent either on chronic diseases, so get your act in shape right now, stay healthy, or 2, it's spent towards your end-of-life care. So let go of that loved one who doesn't need to be on that vent and that peg tube and is dying and writhing in pain and dying, but because you emotionally can't let go of your loved one, you have to learn, now I'm being personal, you have to learn to do what's best for the patient, your loved one, and not what's best for you. And so if you go to these facilities, you see that's why a lot of these costs are so up. There's patients who are on these facilities for years. But that's off topic. But yeah, so it's tied to, obviously, Medicare funding, and when it's going through the roof, the last thing you're going to do is take money away from seniors to pay for a bunch of, again, quote-unquote, wealthy doctors to get training. So.
Okay, the doctor is in and ready to take your questions.
Thank you so much, by the way. That was awesome.
So, yeah, give it up. If you have a question, just raise your hand. We have a couple microphones around the room. We'll come and call on you. Who's got a question for our panel? All right.
What advice would you have for a college student? As you get older, you have to become in charge of your own healthcare and stuff. Some of us are pretty lost.
In charge of your own healthcare?
I just mean in charge of your own health. So I don't really know much about
oh, sure.
When to go to the doctor, how frequently.
Oh, yeah, great question. That's a fantastic question. I would say, obviously, first and foremost, I think an annual checkup is always a great thing, just to make sure you're doing well and not missing anything. That's number 1. And 2, keep an eye out for those check engine lights, right? Really bad fever that's prolonging, headaches that are lasting a little bit longer than usual. Obviously, stomach pains that are not going away. Maybe you're crying for no reason. I'm having a conversation with her, and I just start crying in the middle of the conversation. These are things that need to be addressed. But I think an annual checkup goes a long way in terms of that's 1. And then 2, obviously, just talking to your parents about how you're feeling during your time in college and your mental well-being. hey, yeah, I'm stressed, but is it a normal amount of stress, or are you going crazy with your stress? Are you taking pills to stay awake? Are you supplementing with caffeine pills to stay awake? Are you, I don't know, just doing some things that maybe a lot of people around you are not doing? But having that conversation with your parents, I think it's instrumental. I think UCI also, by the way, has a health clinic on campus.
Yes.
Check them out. Is it free for students, Jeff? Do you know? Does anybody know?
They do.
Oh, perfect. You can always drop by and say hello and just get a checkup if you're, get a free chance. So.
The only thing I would add to that is exercise. If exercise was a drug, it would be a wonder drug. It will protect your physical health, your mental health, and will allow you to live much longer than people who don't exercise, and live better, I should say. Okay.
Okay, more questions. And next, when you ask a question, stand up, introduce yourself, and either your class year or an interesting fact about yourself. Open-ended.
So, hi, I'm Kevin.
Hi, Kevin.
I'm a first year pharmaceutical science major. So, I have a question about like student loans. Like, how did you deal with them?
Student loans?
Yeah.
Oh, you'll pay them back.
Man.
Just don't go crazy. Live like a student when you're a student. What do they say? Don't live like a doctor when you're a student, because you'll be living like a student when you're a doctor. Don't do that. So live like a student. Be judicious. Yeah. But you'll pay them back. It's not a big deal. And hopefully Congress or Senate or something will allow you to refinance your student loans. I think that's the only loan that you can't refinance. It sucks. You can refinance your homes, your cars, everything. That's not your student loans. This is crazy. So.
Back of the
All right.
Hi, I'm Sung Mei. I have a question. A couple days ago, I received an email from UCI said UCI Medical Center is running short on opium IV drug, and they were saying from now on only people in operation room and emergency will be given that. I wonder why in this time of the day we will be running so short supply in the drug for people. I mean, is there any political or whatever reason going on?
So you may have heard that there was a little trouble in Puerto Rico. They had a bit of a rainstorm that blew out the whole island. Guess where the opioids that come into this country are made? Puerto Rico, as well as the IV bags. There's also a shortage of IV bags. So that's the problem. That's why they're running short. And
Go swimming in the water. Gulf of
Right.
Mexico, I guess. I don't know.
More questions. Right here, sir.
Hello, my name is Jimmy Fan, and I'm a fourth year. I was just wondering, what was the hardest obstacle you had to go through in medical school?
Oh, med school? I don't know. I think when you're in medical school, you're guaranteed success in the sense that as long as you just study your butt off, they want you to succeed in medical school. I think the hardest part is going to medical school. I think once you're in, unless you have some type of personal issue. You're gonna have great study classes, study buddies. They'll have tutors for you if you need tutors, but you'll make it. But obviously, it's just diligence and determination. What do they say? It's how much pain you're willing to take in life that determines your success. How much willingness do you have to study day in and day out, 8 in the morning to 5 p.m., take an hour break to work out, study again till 9, 10 p.m. at night. So just good study habits, patience, and avoiding birthdays, celebrations. It's tough. It's emotionally exhausting, but it's so much fun. I really mean it. Yeah.
Dr. Khatibi may be a little humble on the answer he just gave, but hard work,
Yeah,
right?
definitely. Yeah. Good, learn your study habits now.
Hi, Dean Wei. I'm kind of want to know, you said when you try to, you need a trust from the patient. How do you build up the trust?
I think it's rapport, listening, good listening skills. I think it's important. Appropriate physical touch, maybe a shoulder if they feel comfortable. I think that's appropriate. Eye contact is tremendously important in this day and age. We're all computer-driven, typing on the computer, not looking at our patients. Responding appropriately, I think, is instrumental. Actively listening, again. She says something, you listen, and you think about something genuine and smart and intelligent that relates to that conversation. Don't change the subject when she just said, my mother just died, so tell me about this medication. No, I'm so sorry your mother died. How does that make you feel? I'm so sorry. Is there something I can do to help console you? I think that takes time. I think building social skills is going to be so tough for this generation. And I think you need to start working on that. You know, start talking to people. Stop texting people. Yeah.
This side of the room. All right.
Hi, I'm Jessica. I'm a third year. This one is, I guess, a little more broad. It's about medicine. I was wondering your perspective on CRISPR, or when you come across, like, I guess, medicine or genetic tools that could potentially help people, but there's like moral and ethical guidelines that you would, or like lines you would be crossing.
What's CRISPR?
It's like
I thought it was a donut.
It's maybe I'm not pronouncing it right. I just remember reading an article about it. It's altering the human genome, but it would help with genetic diseases. But
So like genetic engineering, genetic modification?
Yeah.
It's a very precise means of modifying the genome.
Wow. You know, I don't know too much about it. Maybe the good professor could talk about it. I'm all about targeted gene therapy. I think that's great in terms of cancer therapy, medications targeting that gene. I used to serve on a board for a company who would do blood testing to determine your genetic tendency for response to a certain medication, your risk for addiction to a certain medication. And we did clinical trials for a year, and I stepped away after a year just because I didn't feel passionate about the science. I mean, they're doing great. I think they just sold their company for a lot of money, but I don't know. I think it's a great direction to go. I think you're right. There are ethical implications in terms of, you know, at what point do we prevent the onset or stop Alzheimer's or Huntington's career or something like that versus making my kid a rock star basketball player or blonde hair, blue eyes. It's a challenge. But I think as society, as an ethical society, I think as a great country, we'll come across those decisions, and I think we'll make the right decision for everybody. But just like with anything else, it'll take some time. Great question.
All right, right here.
My name is Jay. I'm a third year, and my question is, how would you describe your experiences shortly after graduating from UCI and then entering into the real world for the first time?
I felt I was prepared, but obviously a little fearful. In part because you're prepared because the skill sets that you learn here, study skill sets, research and development, social engagement, networking, talking to your superiors, peers, are skill sets which are priceless. And I worked throughout college as well, so I think on campus. So I think UC also afforded me that ability to be employable and understand how employment works, working in teams, working with people of different backgrounds and ethnicities and diversities and viewpoints and trying to figure out some type of consensus to bring them together. And I think UCA gave me those skill sets. But I think when I went out to the real world, I didn't know if I could apply those skill sets accordingly. And so took my first leap, and it worked out great. Haven't looked back since. Yeah. UCI does a great job. Just practice now in a sheltered environment before you go out. Sounds good? Do you work?
Yeah, I haven't.
Oh, what do you do?
I do web development.
What development?
Yeah.
No, what development? It's called what? Oh my God. Oh, website development. I'm like, am I missing out? Oh my God. Good for you.
Okay, we'll do one more question. Do we have a question here?
Hi, my name is Yvonne. I'm a first-year medical student. Oh, wow. I was wondering if you could speak a little bit more about what led you to the field of anesthesiology, and also how you've been able to balance being a clinician in addition to your other responsibilities and your other projects, like the businesses you've been involved in.
Sure. So anesthesiology is, I would love pharmacology. I love drugs. I loved how drugs worked on the body. I love how they influence your body. I don't love taking drugs, but I was fascinated with pharmacology, in part because of my undergrad studies as well as further studies in medical school. So that was part of the reason for anesthesiology. The other part of anesthesiology that I really loved was the physiology aspect of it, right? The most critical time and the most toughest part of your obstacle when you're in the hospital. I knew that I could either treat you accordingly to stabilize you, get you where you need to be at so you can have your operation, so you could, potentially be resuscitated accordingly. And I found that very fascinating. I really enjoyed it. I loved working in the operating room setting. I loved working in the ICU setting. So it was a mixture of both. And I really genuinely loved it. It was that curiosity of going to work every day, coming home, mentally drained, but physically had so much energy, but mentally drained. And that was, I liked that. And I loved all the calls. I loved all the transplant. I just really loved it. But then but then when I stumbled across this like neurocritical care and then pain, I just felt like my skill sets could be used a little bit more, better in a different avenue. So, and you'll find your calling, I think. Just keep an open mind. First question is, do you want to go medicine or surgery route? That's your first question. And then just play around with a lot of the fields. And I think you'll find and you'll change your mind so many times, and it's okay. I'm sure you changed your mind 1,000 times, it sounds like it. How many times have you changed it already? You just started. How can you change your mind so much? Oh my God. Let's get you the phone number for, go ahead. Tell me, how many times did you change?
I don't know. I mean, there are a couple of fields that I'm considering and ones that I've been crossing off.
What are you thinking about?
Ophthalmology is one field.
Okay.
Or
you just want to deal with
geriatrics.
eyeballs all day.
I'm really interested in vision, so I don't know.
That's awesome.
It's neat.
That's great. Uh-huh.
Or geriatrics, but just trying to keep an open mind.
You know what's great? They both go hand in hand. Because most people who have ophthalmic disorders tend to be a little bit older, right? Cataract being one of the most common things, age-related macular degeneration, keratoconus, so many different things, and diabetic retinopathy, more and more people having diabetes. It might be a great option for you. There's a great lab here at UCI. It's run by Dr. Christina Kenny. That's where I actually did my research with Chris Kenny. She's a great friend of mine. We published like 5 papers during my time. I loved her. And then Dr. Cooperman, who's one of the well-renowned retina surgeons in the nation, is at UCI. Actually, UCI is one of the best eye institutes in the nation, with Jules Steen and what's the other one up in LA? Jules Steen and what?
That one is in LA.
What's it called?
Isn't it Jules Stein?
You're not doing your research.
Isn't it Jules Stein?
That's one of them. That's UCLA. What's the other one?
Isn't it Doheny?
Doheny. Yeah. So if I want to say, if you want to go into ophtho, by the way, I would start early. So start doing. Are you doing research right now?
I'm looking into opportunities right now.
You should. There's only a couple months between summer. So talk to Chris Kenny. If you want, I'll give you her number afterwards. Yeah.
Thank you.
All right. Well, in the spirit of that dialogue, we'd like to encourage more dialogue. But first, please join me in giving a round of applause to thank Dr. Nikan Khatibi.
Thank you so much.
And Professor Michael Leon, please.